On behalf of our dean and all of us at the School of Global Public Health at New York University and our co-hosts, the John Bradamus Center at NYU and Just Human Productions, I'm thrilled to welcome you to today's timely discussion on the Omicron variant and what we need to know as we head into the holidays. My name is Julia Cartwright. I'm the Senior Associate Dean of Communications at NYU GPH. I'd like to quickly address some housekeeping issues before the event begins. Questions can be submitted using the Q&A box, and our panel will answer as many as they can, time allowing. We'll also record this talk for those unable to join live. Of note, we're bringing this talk to you in real time with updates coming very, very quickly. The information discussed today will undoubtedly change. So please know that this is a conversation, it's a snapshot in time, and we hope that you find it informative. Now, it's my distinct privilege to welcome today's panel. First, Dr. Elodie Gadin, Chief of the Systems Genomics Section, Laboratory of Parasitic Diseases at the National Institute of Allergy and Infectious Diseases, and an affiliate faculty member with the Center for Genomics and Systems Biology here at NYU. Next, Dr. Celine R. Gounder, a member of President Biden's COVID-19 task force and clinical assistant professor of medicine and infectious diseases at NYU Grossman School of Medicine. And today's moderator, Dr. Michael Merson, visiting professor of global health here at NYU's School of Global Public Health. I'll now turn the program over to Dr. Merson. Thank you.
Thank you, Julia. Welcome, everyone. I know many of you are looking forward to your holidays with family and friends, and we're now faced with a new twist in the COVID pandemic. We have a new variant, and that's what we're planning to talk about today. We're very fortunate to have, as you heard, two outstanding experts and speakers to bring us up to date on what we know and what we still don't know about Omicron. As Julia has said, and let me say at the onset, we're going to repeat that we're in a dynamic, real-time situation. New knowledge and science about the variant is being learned every day. So one of the challenges the three of us have faced in putting this webinar together has been to synthesize all the information that's available as accurately as we can, knowing that some of the facts may indeed change over time. So the plan for the webinar is I'm going to just say a few words, a few slides to put this Omicron variant in context, and then Elodie and Celine are going to cover different aspects of the variant, and then we'll be happy to entertain your questions. So let me start with the slides. First slide. This slide from the World Health Organization shows the course of the pandemic since the beginning. The colors represent different regions of the world. And you can see on the slide that we're entering into now our new wave. And you can see that most of that wave, the increase in cases, is occurring in the Americas, mostly in North America and in Europe. You can't see it that well on the slide because of the amount of cases, but we're also starting to see a peak in Africa, and that's probably related to some extent to the Omicron variant. The next slide shows a similar graph for the United States as a whole, and you can see that, as we've heard on the news, and as you all know, we're now in a new wave, the winter wave, if you like, that's upon us. Globally and for the most part, and domestically for the most part, right now most of this has been the Delta variant, and that is the prominent variant around the world and in the United States right now. The next slide shows a similar curve for the city of New York, and you can see we had our peak, you will remember, last March and April and 2020. And now we are in a new peak that's so far been primarily Delta, but as we'll hear soon, Omicron is upon us. The next slide is a reminder that we have been through various variants in the course of this pandemic. And as I mentioned, the predominant one now has been Delta. And this is a very characteristic of the coronavirus, which I'm sure Elodie is going to talk about. The next slide, of course, is the picture you've probably seen, which is the Omicron variant. And this shows you the spike protein of that variant. You see all the yellow mutations. As you know, the spike protein, as many of you know, binds the virus to the cell surface. Our vaccines make antibodies to prevent that binding. And this, of course, is what's in front of us now, a virus with a lot of mutations. And I know Elodie is going to say more about that. Next slide. And we know that these are now 70 countries that have 80 countries, sorry, that have Omicron now. The first time this was picked up was around Thanksgiving. It was announced in South Africa with a strain that actually had been isolated 2 weeks earlier from a patient in Botswana. And so this strain, the Omicron strain, may have been around, the variant may have been around even back to late October. We don't know. But it's been certainly in the southern part of Africa, South Africa, Botswana, for at least a month now. And then it's traveled around the world to the 80 nations that are here rather quickly. We know that in South Africa that early on, you probably heard that it was spreading quickly. There were many cases. Most of them were mild. There were cases in children. We heard some of these early reports, and there's still a lot of research going on by our colleagues in South Africa, learning more about Omicron. They have had the first experience with it. The next slide shows from The Guardian, a recent article in The Guardian. This has been what's happened in the UK, which has been the second country that has a very good surveillance system. And you've seen how quickly here Omicron has taken off with cases in the United Kingdom. Certainly there's a lot of work going on now in the United Kingdom to learn more about the virus, its transmission, and immunity to it. And then the next slide shows you where this virus now is in the United States. There are 35 states that have reported seeing the virus, and there could be more. These are the ones that have detected it, and it's been spreading quite quickly. Next slide. Yesterday, there was a lot of news coming here in the New York City area. These are just two clippings that in New York and in New Jersey, Omicron had been detected and was increasing at a considerable rate. And so this certainly got the attention of many of us living here in New York City. Next slide. This is just a summary of what I'm hoping now that I've given you this little introduction, what I'm hoping our speakers are going to cover. Is Omicron more transmissible? Is it going to replace the Delta variant? Is it recognized by our current tests? Is it more virulent than our previous variants? Is it resistant to our current vaccines and monoclonal antibodies? Will there be new drugs to treat it? And what about travel over the holidays? These are some of the topics that I'm hoping and anticipating our two experts are going to address. So I'll stop here, Elodie, and turn it over to you to tell us about what you know about Omicron and the virus and our immune response to it.
Okay, perfect. Thank you very much, Mike. So next slide. As Mike has shown, we've seen this again, a representation of what we have seen in the last year. So we've seen how Alpha had taken over in January last year. By April, May, we had Delta that was emerging slightly, a bit like what we're seeing Omicron doing right now. And then quickly by June, July, it had become dominant. So again, it seems that that's what this virus does, is you have these variants that end up dislodging the previous variant. So is that what we will see with Omicron? Far likely, we see that in the UK, the cases have been now doubling every 2 to 3 days. A week ago, we were saying 3 to 4 days. So this just shows you the speed of what is going on. Next slide. So when we talk about this virus having a lot of mutations, I want you to just look at this as a schematic of what would be the spike protein, and each box represents a position in that protein that is potentially mutated. The darker the box, that means the more characteristic that mutation is of the lineage. So if you look at Delta, you have just a handful of these positions that are mutated as compared to the original virus. And when we look at Omicron, we see far more of these dark purple boxes, meaning that Omicron has more positions mutated as compared to the original virus. So that's what we mean when we say there are a lot of mutations. Now, having a lot of mutations does not mean that automatically the virus is more infectious, more transmissible, or that it has all kinds of different characteristics that we can imagine. It just means this is what it looks like. However, the big question is, what impact does that have on our therapeutics, on our diagnostics, on our immunity? And that's what we're trying to find out right now. Next slide. So if we look at the diagnostics, the PCR assay does not seem to be impacted by Omicron. However, if you look at this one very popular assay, which is one by Thermo Fisher, it targets 3 regions of the genome, and you have the schematic below of the different genes in the SARS-CoV-2 genome. And the assay is developed in a specific way where it will need all 3 regions to be positive to call a positive case. Now, in one of these regions, which is of the S gene, there is a deletion in the Omicron genome so that the assay fails in that region. But actually, that's a good thing for the diagnostic assay, because this allows us to identify Omicron very quickly by PCR without having to do a whole genome sequencing, which can take about a week. So that's been sort of an advantage of having that characteristic deletion in Omicron. Now, for the antigenic tests, the jury is still out. Some tests have worked in Germany, for example. I've contacted colleagues who told me their tests still worked, but studies are still being done on this. Next slide. Now, more importantly, does Omicron still respond to our antibodies, be it antibodies through initial infection or antibodies through vaccination? So in these graphs, all I want you to gather from these graphs is that if we take individuals that were infected originally by what was the alpha lineage or the beta, or what has been more popular in the last few months is the delta lineage. And if we take their serum with their antibodies and we put them on different viruses, if we put them on alpha and the person had been initially infected with alpha, their antibodies will bind to the alpha virus and will block it or neutralize it. And so what you see on the graph on the left, you see a high numbers. So the dots are at a high level. So that's what you're looking for. That means there is good neutralization. Now, if you have a different virus, your antibodies can still bind to that different virus. And that's what we see with beta and delta. However, if you can see that sharp decline on each of these graphs with the red dots, Omicron does not seem to be neutralized by infection antibodies, infection to these 3 other infections. So that means the antibodies of convalescence does not seem to block or protect against the virus. Next slide. So the same thing can be seen with vaccination antibodies. So if you were vaccinated with the Moderna 2 doses, or the Pfizer on the right 2 doses, or the AstraZeneca, or in this country, more popular is the Johnson & Johnson. Now, the J&J is also an adenovirus vaccine, so similar to the AstraZeneca, well, you can see that sharp decline in all three cases, especially the Moderna and AstraZeneca on this graph. Now, that means, again, the antibodies do not protect very well. In the AstraZeneca combination with Pfizer, you see a less of a sharp decrease. And that's because there are some antibodies that seem to respond pretty well and protect against Omicron. Now, that's what we see right now. Next slide. However, if you are what we call superimmune individuals, that means if you were infected then vaccinated at some point, those are the graphs on the left, or if you were vaccinated with your 2 doses regimen and you got a booster, then there is a protective effect against Omicron. And that's what those blue lines are showing you. You see an increase in neutralization. That means Omicron is being blocked by the vaccination on the left and the booster on the right. So that's good. Next slide. Now, we often talk about vaccine effectiveness, and that in this case is represented about effectiveness against symptomatic disease. So that means you can still be infected with the virus, but you do not have severe symptoms. And so if we look at those red circles, they represent what would be vaccine effectiveness against the Omicron as compared to the Delta being the black boxes. And where I want your eye to go is with the booster, you see vaccine effectiveness shooting up. So the 3rd dose seems to be quite important in protecting against Omicron. So that's something to remember. Next slide. Now, the good news is that we've talked a lot about antibodies, but our immune response has multiple lines of defense, not just antibodies. And so what has been seen just looking at the genome and the mutations in Omicron is that there are very few mutations in regions that the virus that are targeted by T cells. CD8 T cells, they're well-characterized epitopes or well-characterized regions that the T cells will bind to, and those do not seem to be affected, and it's thought that it's similar for the CD4 T cell response. So we do still have a certain protection, even if our antibodies do not protect us as well as for the other lineages. Next slide. Now, the therapeutics, the bad news is that the monoclonal antibodies do not seem to work very well against Omicron. If you look at the graphs, what you want to see is a response like that green line. And that green line shows you how much of the virus is inhibited at different concentrations of the monoclonal antibody. And the green line is for the original virus, which was the lineage B.1. And we see that for most of the monoclonal antibodies, the Regeneron and Eli Lilly, that pink line, which is for Omicron, is quite flat, except for the Regeneron casirivimab, which requires a higher concentration for inhibition to occur, and the GSK sotrovimab that seems to not be as affected. But in general, most of the monoclonal antibodies do not seem to work very well against Omicron. Next slide. So in summary, we see, of course, that Omicron is really increasing very rapidly. We have to take this seriously. It evades vaccine and infection antibodies, and most monoclonal antibodies do not neutralize Omicron. So that's the bad news. The good news is that diagnostic assays, especially PCR, still work, and the vaccine mix and match and the boosters do help with vaccine effectiveness. So this is something to remember. And again, T cell immunity does not appear to be impacted by Omicron mutations. So that's good news also. Next slide. As for antivirals, the studies are still ongoing. And for everything I showed you examples with graphs of studies that have come out. I've shown you one example. For some of these, multiple studies have come out already. I showed you examples of Pfizer, but for Moderna, studies are coming out too. But the antiviral drug studies are ongoing. And so we will probably get results in the next week or so, or next couple of weeks. So that's it for me, Mike. Thanks.
Great. Thank you, Eleni. Very, very good. And I'm sure there'll be some questions, but very, very clear. Celine, over to you, please.
Sure. No, thank you. So I'm just going to give a little bit more sort of big picture overview of what this means clinically in terms of public health and our strategy. So there are three main characteristics of a virus that we really worry about. So number one is how infectious or transmissible is it? So how easily does it spread from person to person? And if you have one person who is infected, how many other people are they likely to infect? And what we're seeing with the Omicron variant is that this is highly infectious. This appears to be the most infectious variant to date, even more infectious than the Delta variant, which is already a highly transmissible variant. What we're also seeing is that relative to the Delta variant, to sort of put some numbers on it, Omicron appears to be about 2 to 3 times more infectious. So you're likely to infect, if you yourself are infected with Omicron, 2 to 3 times as many more people. And so this is partly why we're already seeing, particularly with indoor gatherings, whether that be in certain occupational settings or with holiday parties, that some of these are turning into super spreader events, because as you can imagine, you only need 1 or 2 people at an event like that, indoors, everybody's socializing, perhaps with their masks off, and that many people can be infected as a result. So that's one characteristic that we think about. Number 2 is immune evasion, which Elodie went over with respect to neutralizing antibodies. You also look at B cell immunity. So how long do you have a memory B cell response that can kick back into gear when you're re-exposed at some point down the line? And then also T cell responses, which are really important in terms of preventing severe disease. And so based on what we're seeing in terms of immune evasion, I would really not count on so-called natural immunity, or the immunity you might have from a prior infection, to protect you, especially from Omicron. That really does not seem to be a protective immune response. With respect to vaccine-induced immunity, so the immunity you have after vaccination, there are also some differences here. The data on the Johnson & Johnson vaccine is concerning. And so if you've had a single dose of Johnson & Johnson vaccine, we would strongly recommend that you get a booster with either Moderna or Pfizer as soon as possible. With respect to the 2-dose mRNA vaccines, Pfizer and Moderna, people do seem to be pretty well protected against severe disease, hospitalization, and death, even with only 2 doses versus Omicron. However, especially in high-risk groups, so people over the age of 50, for example, people who are highly immunocompromised, people who are living in long-term care facilities, so nursing homes, other congregate settings, those are places where very strong advice, please absolutely go get that booster dose as soon as possible. For the general population, also not a bad idea to get a booster dose right now. What we see is that by giving an additional dose of vaccine, you bump up the titers, the levels of antibodies, and you can override some of that relative immune evasion with Omicron by bumping up those titers. And then finally, the third characteristic of viruses that we worry about is virulence. And this is probably the one that we know the least about. The early signals have been good in that it seems that Omicron may be less virulent, but you really need to stratify to drill down, so to speak, on different population groups. So you have to look at how, and by the way, when we talk about virulence, that's really how severe is the disease it causes in an individual person who's infected. And people are different. And so a young person who gets Omicron may have only mild illness, which tends to be the case with COVID in general. younger people tend to have milder illness than an older person. So we really need to look at how Omicron behaves across a range of ages, underlying medical conditions, and then also immune status. So are you somebody who has never been infected, never vaccinated? Are you somebody who's been infected, but perhaps with a remote infection, so early in the pandemic versus a more recent infection? Are you somebody who's gotten 1, 2, or 3 doses of vaccine? And maybe you're even somebody who's been both infected and vaccinated. And each of those groups is going to have a different level of immunity and immune response to Omicron. And so you really have to look at how virulent is Omicron in each of those subgroups before jumping to the conclusion that this is mild. There are some data that have been reported in the last couple of days that might explain how Omicron could be milder, looking at levels of viral replication in the upper airways versus the lower airways. And what we're seeing, at least based on that laboratory data, is there seems to be higher levels of Omicron in the upper airways and what we call the bronchi than in the lungs, which could make it potentially more infectious because you have more virus closer to the nose and mouth where you might exhale those virus particles. And if there's less Omicron virus in the lung tissue, that's really where you worry about severe disease, is when you have failure of the lungs, where people end up on a ventilator. So it is possible, from what we're seeing in the lab, we have some explanations as to why Omicron might be less virulent, but that's not definitive yet. And then I think another thing to really understand is when you have a disease that is highly infectious, even if it causes, on average, milder disease, you can still have many, many deaths from that milder disease. So one way to think about it is a simple formula of deaths equals cases times case fatality rate. So let's say, just for argument's sake, that COVID has a case fatality rate of 1%, and you have 100 people who get infected. Well, you have 1 death. So 100 times 1% is 1 death. But let's say you now have Omicron, and let's say, for argument's sake, Omicron is a quarter as deadly, so 0.25% for your case fatality rate. But let's say you have 400 cases. You still have 1 death, because 400 times 0.25% gives you that 1 death. So we really have to be very careful when we say it's less deadly, it's less severe. You have to be very specific what you're talking about. And at a population level, Omicron could be just as deadly as Delta, even if it causes milder disease, if more people are infected.
Is that Celine? Can I ask you to comment on the new therapies?
Sure. So there are 2 new antiviral pills that are, well, in the case of molnupiravir, has already received an FDA emergency use authorization. Paxlovid, we're hoping any day now. Molnupiravir, there are some issues. So that's the Merck drug. It seems to be only about 30% effective in preventing severe disease, hospitalization, and death when given within 3 days of symptom onset. So it needs to be given very quickly. You really need to be testing people quickly and starting them on therapy very quickly for that to have any impact. The other issue with molnupiravir is concerns about mutagenesis, which means concerns about genetic mutations. So in particular, for women who are pregnant, where you have a developing fetus, you really don't want to be giving molnupiravir because that could potentially cause congenital abnormalities. So there's a lot of concern about the routine use of molnupiravir, because it does require appropriate screening of patients to make sure that it would be safe for them. And it's only 30% effective. With respect to the Paxlovid, to the Pfizer drug Paxlovid, this is a combination of 2 protease inhibitors, one of which we have used for decades now for HIV, ritonavir. The ritonavir is used to boost the levels of the other protease inhibitor. And so the mechanism of action here is different. The effectiveness of Paxlovid appears to be excellent when given within 3 to 5 days after symptom onset, about close to 90% effective in preventing severe disease, hospitalization, and death. So that's really great. And the main issue with Paxlovid is drug-drug interactions, because one of the components of Paxlovid does boost the levels of many drugs, not just the other component of Paxlovid. So for example, if you are on a blood thinner, if you're on certain antibiotics, birth control, a number of other things, there could be a drug-drug interaction. So that does need to be reviewed carefully with a pharmacist. The good news is it's only a 5-day, 5-day? Forgetting now, but it's only a few,
5 day, right.
it's a short course. So you don't, it's not an ongoing issue with drug-drug interactions. It's just for that window. But again, we need to have a system where people can get a rapid test, can get initiated on the drug as soon as possible so that they are still within that 3 to 5 day window. I certainly can imagine a future where breakthrough infections are not uncommon. I think we're already seeing that, frankly, with triple vaccinated people and Omicron, but they're pretty mild infections for most of them, for vaccinated people. So I could see a future where something like Paxlovid becomes sort of your safety net or backup. Everybody's vaccinated, but then if you happen to have a breakthrough infection, that would be a situation in which you would take Paxlovid. And then of course, more frail, vulnerable, older people, this would probably be a drug we turn to not infrequently, because there's a phenomenon of immunosenescence where your immune system just doesn't respond as well to vaccination as you get older. Your immune system doesn't remember as well. And so that population is more likely not only to have a breakthrough infection, but to go on to more severe disease. And so I think that will become more and more routinely used, especially in those high-risk groups.
Thank you, Celine. Wonderful overview presentation. We have many, many questions coming in, and I'll try to do as much justice as I can to them. To either one of you, but how bad do you think the winter is going to be? In particular, there's questions about the healthcare system, and is there anything we should be doing differently? This is, of course, not just in New York City, but in general. Any thoughts on where we're headed as a result of what's in front of us?
Yeah, I can take that. I think you already have some hospitals that are putting a pause on elective surgeries, for example. We are heading into holiday season when we often are working with a skeleton crew in the hospital, as is. And to be honest, healthcare workers are exhausted. After 2 years of this, to say to folks, you may have to come in off your break, your time off to help pitch in, I don't think that's going to go over very well, frankly, for a lot of people. So I think the more we can do to preserve our healthcare system capacity to offload healthcare workers by not sending people to the hospital. And when I say that, I don't mean you're sick, you don't go. I mean, not getting sick in the first place. So I think some of that means if you're not yet vaccinated, please get vaccinated. If you're not yet boosted, get your booster. But then also do all the other things to help alleviate pressure on the healthcare system. So that would include masking. We are really recommending that people up their mask game, especially now with Omicron and even with Delta, which are more infectious. It's really important that you wear an effective mask, especially when you're indoors around other people. So that would include an N95 respirator or a KN95 or KF94 mask. The KN95, KF94 are not quite as good as the N95 respirator, but they are superior to a surgical mask or a cloth mask, and they do provide a tighter fit around the face, so you have less air leakage, and so therefore less transmission potentially occurring. In addition to that, in interior spaces, making optimal use, maximum use of ventilation and air filtration. Here in New York City, it's 60 degrees today. We could certainly be opening doors and windows comfortably, creating a cross breeze Also, if you can afford to buy HEPA air filtration units to put them indoors in the home, particularly in spaces where people might gather. So kitchen, living room, dining room, family room, that sort of thing. And then to the degree that the weather allows and people are willing to do so, having gatherings outside. The president, for example, is hosting a holiday party on the roof of a building which will be outdoors. Understanding that that was the safest way to host a holiday party. So this is certainly something that others are doing. And then finally, rapid testing, we still have some concerns. We're still studying how well the rapid tests work for Omicron. So I think that's one of those stay tuned. But at least with Delta, the rapid tests were a very useful tool, and Delta is still the dominant variant. Rapid tests were a very useful tool to assess if you were infectious to others and whether you might be able to shed that mask on a day when you had a negative rapid test. So those are some of the tools. And I think we really do need to anticipate there probably will be a surge, an increase in hospitalizations over the coming months. We were already at the beginning of a Delta-fueled surge heading into Thanksgiving. And then, of course, on top of that, you now have Omicron. So I think we really do need to be prepared for that.
Okay, Elodie, here's one for you. How does one know if one is infected with Omicron or Delta?
Well, so the most of the PCR tests, it would have to be a PCR test to tell you that, but not the same PCR test is used everywhere. So the test I mentioned is used in certain regions and not others. And but now I know of many areas that are switching to that particular test that allows to know what it is. However, in general, when you get a PCR test, you will not get a response back that tells you what lineage you have, simply because it would be impossible for the labs to do that. So, however, that information is sometimes provided to the public health labs for epidemiological reasons. So unfortunately, you will not be able to get that information when you go for a PCR test out in the community. If you're doing it through some kind of research entity like the NYU, for example, it's possible that they would provide that information, but I highly doubt it. So the short of it is you will not get that information.
Okay, let me ask you another one, which quite a few people are asking. If I've had my, let's say, 2 Pfizer doses,
Right.
I had a booster as soon as I could get it. When do I'm going to need another booster to guard against Omicron? People are asking that. Any thoughts on that?
So I was reading the questions in the chat, and they're all a version of exactly that. So if I had, my 2 Moderna, or if I had the AstraZeneca, the Johnson & Johnson, whether also I need a booster that's just 1 dose of Moderna versus 2 doses of Moderna, same thing for Pfizer. And Celine, I don't know what you recommend, but I think with 1 dose, it's like a boost, basically. So the data do show that 1 dose of Moderna, 1 dose of Pfizer after a J&J or after an AstraZeneca does boost the antibodies. Now, I've known people who have gotten like a full regimen of Moderna or Pfizer after a J&J regimen. So I don't know, Celine, what is advised by?
Yeah, so I would say if you have gotten 2 doses of AstraZeneca or 1 dose of J&J, get 1 dose boost with either Moderna or Pfizer. If you have gotten 2 of Pfizer or 2 of Moderna, get 1 more of either. I think this is where, and this is something that's actively being debated by policymakers, by scientists, is what are the goals of vaccination? So is the goal of vaccination to prevent all infection, even if it's as mild as the sniffles, or is the goal of vaccination to prevent severe disease, hospitalization, and death? Is the goal of vaccination to prevent long COVID? If our goal is to prevent all infection, including the sniffles, we're going to end up having to boost people a couple times a year. And apologies, that's my dog getting excited in the background. So in any case, I think we have to reset a little bit what it is we're trying to accomplish and why. There are also diminishing returns on repeatedly boosting, particularly if you look at particularly if you look at the memory immune response. And so there may not be added protection, particularly against those more severe outcomes.
But I think that answered the question really
Right,
well.
I think what people are thinking is, are we going to be in the booster forever? And
Yeah,
I guess
but we have to
really-
remember that vaccination is often to prevent severe disease, and that's how we measure vaccine effectiveness also, right? You can still get infected. Either you have very few symptoms or you have a few symptoms like cold-like symptoms, and that should be an acceptable outcome, basically.
So let me just follow right on with that, which is a question that many people are asking, and that is, do we need to change our mindset a little bit and think of this more as an endemic situation where we would have a vaccine periodically and treatment, maybe more like influenza, maybe not, but is there a mindset that might need to change? I know Dr. Fauci talked today even about a universal coronavirus vaccine, as we've been trying to do for influenza for quite a while now. So I'm just thinking, I don't know, Elodie and Celine, is that where we're headed?
I think it's important to define what is endemic, because unfortunately, this is one of those epidemiologic terms that has been misused over the course of the pandemic. You know, at the beginning, it was, oh, COVID is nothing but the flu. Then it was herd immunity. Then it was, oh, we're endemic, or it's an endemic now, which really is all about saying, let's do nothing. So I think we have to be very careful what that means. The way I think about what is epidemic versus endemic is really the shape of the case curve. So when you're talking about epidemic, you're seeing the curve do this with cases. When you're talking about endemic, the curve does more of this wavy, you know, more like ripples in a pond. You're not getting those big spikes. And if you look at the case curve, we're nowhere near endemic right now. We're still very much epidemic. So I think that's number one. But I do think long-term, our goal should be, how can we reduce severe disease, hospitalization, and death? How can we turn COVID into something much more like the flu or the common cold through vaccination? That's how you get there. And then, yes, if you have these mild breakthrough infections, you know, so an infection after vaccination, that is not morbid, that does not land you in the hospital, that does not kill you, frankly, that's a win. In a sense, what you're doing by vaccination is you're hitting the fast forward button on that transition from pandemic or epidemic to endemic, to a more controlled state. But we're not there yet in terms of our vaccination rates. We've leveled off at about 60% fully vaccinated in this country. Even countries like Denmark that are at about 80% fully vaccinated are not quite there yet. We really need to be getting to 85, 90% of the population fully vaccinated to get to that point.
Elodie, you want to add anything, or?
No, it's funny when you were talking about the curves. If you look at flu, so flu in the tropical countries is often endemic, truly like you describe, where it's there all year round, while in the southern hemisphere, they are truly epidemic for flu. But yes, we're not there with SARS-CoV-2 at all.
So here's a very practical question. If I've received 2 doses, my second dose though was less than 6 months ago, should I cheat a little bit and get my booster now with Omicron on the horizon?
Well, it's not cheating.
Well, it's supposed to go 6 months, it says. So should I do it sooner?
I don't think there would be any harm. There is some debate as to the best timing of the boost. But again, I think this idea, I mean, I've been asked, well, what about my 5th dose? What about my, you know, I think we need to step back a little bit and ask, what is it we're trying to accomplish? And I think reboosting and redosing every couple months is really not going to get us there. I think you're going to get some short-term benefit. But that's just not a sustainable public health approach to this.
Okay, I guess obviously J&J would be different, but with the mRNA vaccines, you would be patient and recommend waiting the 6 months.
I don't feel strongly about that, but it's more that, okay, now if you get it today, does that mean you have to get another one in another 4 months and then another 4 months? And I mean, I literally get that question of, how often can I get it? How often can I possibly get it?
Right.
And I, the idea that you would get it every 3 to 4 months, even yearly, I think, again, we have to step back and say, what it is it that we're trying to prevent? And if all we're trying to do is prevent sniffles, a mild infection, that's just not a great use of public health resources.
And Elodie, any thoughts on that?
No, and I totally agree with Celine,
Okay, now there's interesting questions about if being around others that are not vaccinated. If I go, if I'm vaccinated and I'm even boosted, and I now find myself in a barbershop or a hairdresser, I don't know who's vaccinated and not vaccinated. So, what is that a greater risk? What do I do? How do I navigate that?
So I think it's helpful here to understand what we mean by vaccine efficacy. So what is the equation for vaccine efficacy? That is the percent risk reduction relative to an unvaccinated person. So let's say it's a 90% effective vaccine. The risk in your community for somebody who is not vaccinated, let's say, is 100,000. If you reduce that by 90%, that gets you down to 10,000. If you still have that 90% effective vaccine, but the community risk is 100 and you reduce that by 90, that gets you down to 10. So in both scenarios, you have a 90% effective vaccine, but in one scenario, your risk is 10,000. In the other scenario, your risk is 10. So those are clearly not equivalent risks. And I think this is where in trying to explain, vaccines work best at a population level. And the more people who are vaccinated around you, the more you get protected. It's a synergistic thing. And I think people need to understand vaccines are not on-off switches. They are very much synergistic with the vaccination status of the people around you. So yes, the short answer is, even if you are vaccinated, if you're around a bunch of people who are not vaccinated, there is absolutely still a risk.
And the question is, I guess, Mike, what you were saying is that you don't know who's not vaccinated around you when you go to the barbershop or the hairdressers or whatever you do. And so do you change your behavior assuming everyone is not vaccinated, right?
Right.
So that's a personal risk that, in this case, it's a personal risk you're taking for yourself and for your family, and so that's the choice, I guess, that people need to make at this point.
Okay. So here's one for you, Elodie. What about someone? Is it theoretically possible that you could be infected with an Omicron and Delta variant at the same time?
Oh, good question.
And if so, what does that mean? Is it more deadly? Are we going to have to look for a new mutant? How do you size that one up? Yeah,
that's a great question. Actually, we don't know yet. That's exactly the kind of thing I do in my research, where we look for co-infections. Yeah. And so we're looking now. We always assume that when you have something new circulating in the population and there was something else that was already there, that there is a chance that somebody could be co-infected. With Delta, we didn't see any co-infections because Delta competed everything else out, right? So, we haven't noticed any cases of co-infections. It's possible that there will be some. We don't know what this means for disease severity. I don't think any animal studies have even been done on that yet to, co-infect with the two viruses and see what happens. However, there is suspicion that there are cases of co-infections, especially in areas of the world in populations population where you would have a lot of immunocompromise, where that means people could be infected for a very long period of time because of an immune system that does not work very well. That means you could have a super infection. That means two different viruses that infect the same individual. And so we suspect there could be what's called recombination, where the resulting progeny of these viruses, what happens as the viruses evolve, they can be in contact with each other, and there could be an exchange of genetic information, and you would have a new variant that occurs. It's thought that one of the lineages of Omicron right now, there are 2.5 lineages right now. There's what's called the BA.1, BA.2, and an outlier. And it's thought, so most of the Omicron cases have been BA.1 right now. There's a handful of BA.2, and it's thought that the weird outlier is a recombinant. It's a mix of lineages, but we're not sure what they are exactly. So the short answer is yes, we do suspect there will be probably recombinants popping up. We don't know what that means for transmission, infection, and severity.
And of course, the fact that the virus lives longer, we think, in immunosuppressed individuals has been one of the theories why even in South Africa and Southern Africa, the Omicron variant even showed up. And
exactly.
So, I mean, this is an interesting theory. One thing we haven't covered, we don't have a lot of time, but it is the Omicron in children. And I know we're still waiting on data, but I just wondered if either of you want to comment on that. With schools closing now for the recess, and what can we expect? A lot of parents thinking what to expect when they return from holiday. And either one of you want to comment on or speculate on the vaccines, how well they're going to work against Omicron in children? Do we have any data at all to help us yet?
You know, there's still, the jury's still out on how virulent Omicron will be for kids. So I really hesitate to say too much on that. We don't know is the short answer. I would say if your child is 5 and up, eligible to be vaccinated and has not yet been vaccinated, I would absolutely get your child vaccinated. I would not rush to get a booster until 6 months after their initial series of Pfizer or Moderna, whichever one they end up getting. But I would say that's the most important thing you can do right now to protect your child with respect to Omicron.
Elodie, you have any immunology data that'll help us yet?
No, there isn't. I don't think there's any clear data just yet. But one thing of the epidemiology of the fact we're going into a holiday where kids are staying home from school is actually a good thing, because we do see in flu, for example, that during the holiday season, cases of flu decrease because kids often are transmitters to their families from their contacts at school. And Omicron being so transmissible, that would probably be the case. If this had occurred in the fall, it probably would have been worse right now already with transmission. So that's the one silver lining that we're going into the holidays.
Okay, well, we'll just have to wait on that. I don't think we can say more than that right now. All right, well, we don't have a lot of time. Let me just say a little bit. I had one slide I wanted to put up, and then I'm going to ask each of you to give a final thought, and that has to do with travel. I know that there's a lot of questions being asked about travel, and I know many people plan to travel. And I just have a few thoughts, which I think have all been really said already by our experts. But let's first remember that we have Delta and Omicron among us, and primarily Delta right now. We're going to get more Omicron, but please let's remember it's still primarily Delta. How long? Certainly here in New York City, there's a lot of thinking that Omicron may be here dominant by the end of the year. Who knows? It's with a doubling time of at least 2-3 days. We don't know, but if it keeps going the way it's going, we may see it here in the Northeast, but it may not be everywhere. Certainly till later in January. We're a big country, and we tend to have waves in regions very often in the way the pandemic has played out. So first is to remember that we know the vaccines are very effective with Delta. We know they are, as you heard, with a booster in particular, they work against Omicron reasonably well, maybe not preventing infection, but certainly preventing severe disease, as we've heard today. And we just heard the importance of vaccinating children, age 5 and older. There's no reason not to do that. And that should give us, we hope, not only the protection against Delta, but some protection against Omicron. We've heard about rapid testing, the importance of testing, and I think that's a real tool for traveling. And is some, if you're in a situation, be prudent, be careful, use testing, the rapid test, when you might feel you might be at risk for anything you've done, or you're concerned about expose someone who you're with who might expose you. Test at the door, I've heard said by a number of people, but there are good tests available. They certainly are fine for Delta. Still a little bit of data needed on Omicron, but let's make use of our rapid testing since those tests are available. We've heard about good masking. Celine, you pointed out the importance of having the right mask and keeping it on. One of our questions was from someone who says, I'm the only one wearing a mask in my city or in my town. Well, that's not a good idea. I think we need to still use masks in the right situation, particularly when we're in indoor crowded spaces. We need to have good ventilation, hand washing still useful, and keeping a distance. But really, I think the most important thing in traveling, know your risk and the risk of your family and friends. And use the right judgment. We have the tools we need, and I think it's awfully important to spend the holiday with family and friends, but do so wisely. And that's my general advice about travel. So let me ask Celine, and Elodie, do you want to either one? Elodie, you want to go first? Do you have any closing thoughts?
Yes, trust your instincts. Believe it or not, in the last close to 2 years, you've developed a feel for what feels too close and what feels safe, and basically trust yourself. This is not April 2020. You have learned a lot in the last 2 years.
Well said. Celine?
I would just remind all of us that we have now crossed the 800,000 death mark. We have lost 800,000 Americans to COVID as of this week. 3/4 of those deaths were in people 65 and older, and people of color, Black, Latinx, and Indigenous people were twice as likely as white Americans to have died from COVID. And I really think we need to keep that perspective in mind as well, understanding certain populations have been hit especially hard, are more vulnerable, and that we do need to be thinking a bit about how to protect those most vulnerable around us in addition to ourselves.
Very important, reminding us of equity and the need for everyone in this country. And of course, we haven't had time, but also abroad. And let's remember that all but one of these variants had really came out of a lower middle income country. And so this is really a global pandemic. And we're all in this country together, but we need to all be in this together as a world and think a lot about that as we move forward. Julia, I think our time is up. So let me thank the panelists immensely. You've been wonderful and informative, and let me wish everyone here with us a happy holidays.